Bismillah ar-Rahman ar-Rahim. We'll start now with a session about the international guidelines in breast cancer. Before starting the session, I would like to thank the organizer of this meeting for giving me the opportunity to share in this meeting. Also, I would like to congratulate Dr. Hesham Elghazaly for this very great conference and very successful meeting. This is not this year only, it is the sixth conference in succession. I would like to welcome also the co-chairmen with me, Professor Dr. Abbas Omar and Professor Dr. Tariq Hussein. And the first talk will be presented by Professor Hesham Elghazaly. It will be about BGICC guidelines in neoadjuvant multidisciplinary management of breast cancer. Please, Dr. Hesham.
Thank you very much, Mr. Chairman. And this is the BGICC International Consensus for Neoadjuvant Multidisciplinary Treatment in Breast Cancer. 34 of international expertise in breast cancer in all subspecialty had met during the 5th BGICC last year to put the first fulfilled consensus about neoadjuvant management in breast cancer. The methodology behind this, the working groups of the BGICS multidisciplinary groups prepared clinically oriented preliminary recommendations involving the whole aspects of neoadjuvant management of breast cancer, either operable, locally advanced, or inflammatory, including radiology, pathology, surgery, radiotherapy, and systemic therapy. These recommendations were circulated to all panel members by email for comments, adding, removal, or corrections on content and wording. A final set of statements was presented, discussed, and voted upon during the consensus session of the 5th BGICC January 2013. All panel members were instructed to vote on all questions, with members with a potential conflict of interest or who did not feel comfortable answering the questions instructed to abstain from voting. The 34 international panel experts are from several geographical regions from the world and involving the management of breast cancer from all specialties. Those are the expertise involved in the consensus panel discussion and these recommendations. And this is the geographical distribution of expertise, including those from Europe, Egypt, Middle East, and United States. And this is the specialty distribution of expertise, including surgery, radiology, pathology, radiotherapy, and medical oncology. And the topics of discussion involving 6 important points about the radiological assessment, including the pre-treatment evaluation and the evaluation of response, pathological assessment and its impact on response, surgery, role of radiotherapy in neoadjuvant treatment, chemotherapy, hormonal treatment, and targeted therapy, and inflammatory breast cancer. Firstly, the radiological assessment. All the panel members agreed that the first imaging assessment of the primary breast tissue in patient planned to receive primary systemic therapy is sonomammography and not MRI. On the other hand, the best modality for assessment of complete radiological response in the neoadjuvant setting is MRI and not sonomammography. So the panel had agreed sonomammogram for initial evaluation before the primary systemic treatment, and also agreed that the best modality for assessment of response has to be dynamic MRI. Evaluation of response must be done in mid-treatment before switching chemotherapy and at the end of the chemotherapy. Another important point about the type of biopsy, and all the panelists, or most of the panelists, agree that the tissue biopsy must be multiple cores, at least 4, and it's advisable to perform under image guidance. And all accept to prepare ourselves for success and to insert clip or marker before surgery or before starting neoadjuvant chemotherapy in those patients who are planned to do conservative breast surgery, except inflammatory breast cancer and those associated with microcalcification. 92% of the panelists agreed for that. Controversial point about the role of PET-CT in assessment and evaluation of breast and axilla. And the BGICC panel had discussed the role of PET-CT in assessment of response and assessment of axillary lymph node. In spite, there was agreement about the use of PET-CT in assessment of response, but it was a point of controversy, and they stated that this point may want further data and study to evaluate and explore this point. And returning to literature, we find that the role of PET-CT has the PET-CT has accuracy and sensitivity and specificity lower than those of MRI, and this also confirmed by the meta-analysis showing that the bold sensitivity and the bold specificity of the PET-CT is 84 to 60% consequently. Another important point is the effect and definition of multifocality, multicentricity, and diffuse microcalcification, and its effect on the breast conservation surgery. And the panel has considered the multifocality, which was defined as the presence of more than one lesion in one quadrant of the breast less than 2 centimeters apart, is not a contraindication of conservative surgery, and 80% of the panelists agreed for that, while the multicentric breast cancer is considered as an absolute contraindication for breast conserving surgery. Diffuse microcalcification, if previously confirmed to be ductal carcinoma in situ, and this is the addition of Professor Maria Cardozo, throughout the breast is considered a contraindication for conserving surgery, and most of the panelists agreed for that. Actually, 3 months later, in the Sanganen recommendation, they stated that there is no single cause of, or there is no single absolute contraindication of breast conservative surgery, either multifocality, multicentricity, and even extensive or diffuse microcalcification. Again, very important issue about the rationale of neoadjuvant chemotherapy. And all we know that meta-analysis of about 5,500 women that show that the overall survival, disease-free survival, is the same, either to give the treatment on adjuvant basis or neoadjuvant basis, while there is increase in breast conservation rate and no increase in local regional recurrence in patients receiving neoadjuvant treatment. And the most important point, those who achieve pathological complete response have a better overall survival than those with no improvement or no pathological complete response. And here the results of the NSABB B18 and 27 with improvement of overall survival and disease-free survival in those achieving pathological complete response than others. And it is very important to define the pathological complete response, and we are all with the Hanisi definition of pathological complete response with complete disappearance of invasive lesion in either the breast and the axillary lymph node. As we see here, those who achieve pathological complete response in the axilla have an overall response survival and overall disease-free survival better than those who have a residual disease in the lymph node. And this is not the case in a patient with breast lesion achieving pathological complete response. Also, the panelists agreed that the patient with inflammatory and inoperable locally advanced non-metastatic breast cancer should receive primary systemic therapy, and those with inoperable breast cancer, the neoadjuvant therapy is not given only to enhance breast conservation. And we have other issues for that, may improving the outcome of the patient in subgroups of some patients with breast cancer. Also, the panel had universal agreement that the response to neoadjuvant treatment is the most powerful predictor of long-term outcome. Again, a very important issue about the impact of pathological factors in outcome and decision of treatment. All we know that the breast cancer is not single disease. We have 5 different diseases based on 4 factors: the estrogen receptor, progesterone receptor, HER2, and the Ki-67, with the subclassification into luminal A, who have estrogen receptor positive, progesterone receptor positive, Ki-67 less than 14%, and HER2 negative. Patients with luminal B1 who have estrogen receptor positive, progesterone receptor positive, HER2 negative, and the Ki-67 high. Those with luminal B2 who have estrogen, either estrogen receptor or progesterone receptor positive, HER2 positive, and any Ki-67, and those who have HER2 overexpression with negative hormonal and positive HER2 and the basal-like or the triple-negative disease. And the spectrum of sensitivity of the treatment is completely different, ranging from endocrine sensitive and cyto or chemotherapy resistant in patients with luminal A disease to endocrine dependent and to endocrine chemotherapy sensitive and endocrine resistant in patients with basal subtype. Also, the panel had totally agreed that the high-grade tumor as well as the estrogen receptor negative tumor are associated with better response to neoadjuvant treatment. And also, despite there was a controversy or discussion about the standardization of how Ki-67 was done, but Ki-67 evaluation is advisable before the primary systemic therapy, and 66% of the panelists agreed for that. Here, the panelists discussed the indication and the need for chemotherapy in patients with primary systemic therapy. If the chemotherapy is indicated in all cases, or we can classify according to the cells and the subtypes of breast cancer. So in patients who have proliferating breast cancer, proliferation with Ki-67 lower than 14%, the chemotherapy is advisable for those. It is a controversial point. And those with high endocrine responsive disease, like lobular carcinoma or classical subtype, the chemotherapy is not recommended. And those who have triple negative disease, the neoadjuvant chemotherapy is more preferred in those patients than the adjuvant treatment, and 65% of the panelists agreed for that. Then going to the systemic treatment, chemotherapy, hormonal treatment, and targeted therapy, and the panelist has universal agreement that the whole course of the chemotherapy should be given upfront, and that is, should contain taxanes and anthracyclines. For patients who have overexpression of HER2, the neoadjuvant regimen should contain anti-HER2 treatments. The panelists agreed to stop chemotherapy after the full course of chemotherapy, even if there is a residual disease either in the breast or in the lymph nodes. This is area, I think it is important area for clinical trials, and also the most panelists consider the neoadjuvant endocrine therapy a reasonable option for highly endocrine responsive postmenopausal patients. And there was agreement in the St. Gallen for this, and this is typical for the St. Gallen recommendation, who also recommending to give all the chemotherapy before surgery, and they recommend also to give no chemotherapy after achieving pathological complete response, or to give no chemotherapy even if there is residual disease after the end of neoadjuvant treatment. Then go to the surgery and lymph node assessment. And the panel had disagreed that in clinically negative axilla, the sentinel lymph node biopsy should be done before the primary systemic therapy. And in case of isolated tumor cell or the presence of micrometastasis in the sentinel lymph node dissection is not indicated. Going to the role of radiotherapy, and all the panelists agreed that the post-operative radiotherapy should depend on the initial presentation of the tumor, and there was a controversy regarding the partial breast irradiation as an alternative to standard radiotherapy technique, and this is going with the St. Gallen recommendation regarding the partial breast irradiation with the same percentage is about 40% in the BGICS guidelines, and it's about 36% in St. Gallen guideline. Then regarding the inflammatory breast cancer, the BGICC panel has agreed that the inflammatory breast cancer is a clinical diagnosis that requires pathological confirmation. Upfront, the chemo-targeted therapy is the standard of care, and the chemotherapy protocol is the same as in adjuvant settings, including anthracyclines and taxanes. Also, the panelists stated that there is no role of conservative surgery, skin-sparing mastectomy in inflammatory breast cancer, no role of sentinel lymph node biopsy, immediate breast reconstruction, even if the skin biopsy revealed the complete response to chemotherapy. So from these, we have important points for the future that the neoadjuvant or primary systemic therapy is a challenging zone that perfectly defines the need for multidisciplinary management. Primary systemic therapy is an important category, especially in our region, due to the difference in patient characteristics, also represent a very hot area for clinical research and drug development. And the collaboration between the international, regional, and all the groups is mandatory for better achievement of tailored multidisciplinary recommendations that guide the practitioners in detecting, diagnosis, and treatment of patients. All efforts must be done by the regional organization concerned by cancer care, either governmental or NGOs, to enhance multi-center, multinational clinical trials that help to better defining the strategy of treatment of our patients. And I ask you all not to miss the banner recommendation in multidisciplinary management of breast cancer in young women tomorrow at 5. and thank you very much.
Thank you very much, Dr. Hesham. And I think we have some time for maybe 2 questions. Otherwise, the secretary of the مؤتمر هيضربنا. We have time for 2 questions. Any question? Yes, Dr. Tariq.
What about bilateral breast cancer? Is there any recommendation as regards the primary systemic therapy?
I don't hear you well.
Bilateral breast cancer.
Bilateral breast
simultaneous breast cancer.
So
in
the
both sides.
neoadjuvant treatment in bilateral breast cancer?
Yes.
So I think the same. We don't have any recommendation about bilateral breast cancer, but I feel, in my opinion, that it's the same in bilateral like unilateral breast cancer. If we have locally advanced bilateral breast cancer, we must go for neoadjuvant treatment first. It is the same like unilateral breast cancer.
Okay, any other question?
My question about, you said that if you are deciding to give neoadjuvant chemotherapy, we don't have to do, first, if the patient is clinically node negative, we don't need to do a sentinel lymph node. I don't know why. In the NCCN guidelines, it is recommended to do sentinel lymph node if the patient is clinically negative in order to spare axillary dissection.
Yes, I totally agree with you, and I think this is a recommendation is against even the Sangana recommendation. I think because we have in the region we have no good experience in the sentinel lymph node biopsy.
The other one, you said that the inflammatory breast cancer is a clinical and pathological diagnosis. I think it become now just clinical diagnosis.
Yes, this is, it was a point of controversy, and Professor Joseph Vialli was there. He is a well-known pathologist, and we agreed that it is, we will start firstly to try multiple bunch biopsies to define the pathological proof of inflammatory breast cancer, or if not, we can depend on clinical entity of that it is inflammatory breast cancer.
It is still recommended that we have to take a biopsy to be sure that it is a inflammatory breast cancer? Thank you.
Thank you very much, Dr. Hesham. Thank you.